Hey everyone, we are excited to launch the Bright Mind subscription. Unlimited access to all of our CE courses, webinars, and expert speakers all in one place.
And for a limited time for the month of December, you can get 50% off. Normally $299 a year, now just $149 for your first year.
That's unlimited CE on your schedule for half price.
Head over to psychedpractice.com and click sign up, and the discount is already applied. We look forward to seeing you there. And as always, be well, stay psyched. This episode of the Psyched to Practice podcast is sponsored by PAR, where psychological assessments meet innovation.
PAR has been the gold standard in the industry for over 45 years and has empowered professionals in education, healthcare, private practice, and research with trusted tools and cutting-edge solutions.
Discover more at parinc.com. Again, that is parinc.com. Creating connections, changing lives.
Welcome to the Psyched to Practice podcast, your one-stop for practical and useful clinical information, masterful insights from experts in the field, and a guide to daily living. I'm your host, Ray Christner, and today I'm flying solo. Paul was unable to be part of the recording today, but we had a great chance to have on our show two just excellent providers, Dr. Carmen McLean and Dr. Elizabeth Goetter, who joined me today to talk about prolonged exposure and a little bit about the book that they wrote together. And it was really just a great opportunity today to really learn about a topic that I did have myself some already existing knowledge, but to really get deeper into understanding prolonged exposure and a little bit about maybe some of the misconceptions that people have, but also to talk about the evidence and how it can be used specifically with post-traumatic stress disorder. And so both Carmen and Liz wrote a book, Prolonged Exposure for PTSD. Innovations to improve access, engagement, and outcomes. And in this book, they really provide some interesting information about kind of emerging trends, how we use it in telehealth, ideas of digital ways to use it, as well as adaptations that we might put in place for specific populations. And we got a chance to really kind of take kind of a dive into all those areas. And again, kind of a really fun episode for me to be a part of. For those of you who do not know our guests, Dr. Carmen McLean is a licensed clinical psychologist and a clinical professor at the Department of Psychiatry and Behavioral Sciences at Stanford University. Dr. Elizabeth Goetter is a licensed clinical psychologist, associate professor, and director of the psychology doctoral program at LaSalle University in Philadelphia. So again, great opportunity to have them with us today. For those of you who do prolonged exposure work or have interest in it, we'd love to hear from you. Please take a moment and check us out on social media. We'd love to hear some comments from you and feedback about this episode and maybe thoughts you have on this topic. So again, hope you enjoy this episode, Prolonged Exposure for PTSD. Carmen and Liz, thanks so much for joining us on the Psyched to Practice podcast. We're so excited to have you to talk a little bit about your book and about prolonged exposure. So thank you so much for joining us.
Thank you so much. Happy to be here.
Great.
Thank you, Ray. It's a pleasure.
Absolutely. So we like for our show, as we're talking to guests, to kind of start out getting kind of an origin story, like how people got into the field of psychology in the first place, and then what led them into their areas of expertise, such as what you all do with your book. So maybe, Carmen, if we could start with you, can you tell us a little bit about how you got into the field?
Sure. So I was quite lucky to have a father who was a clinical psychologist. So I got into the field partly for that reason. And I went to grad school at the University of Nebraska. I worked with Deborah Hope, who's an anxiety expert, and learned about cognitive behavioral therapy. I was always really drawn to kind of behavioral approaches, something about, I think, just the directness of behavioral approaches was appealing to me. And then for postdoc, I had a great opportunity to work with Dr. Brett Litz at the VA. And that was my first foray into PTSD specifically, and working with the military and so on. That was a tremendous learning opportunity. And I really enjoyed working with that population. And then I went to the University of Pennsylvania, and I worked for about 6 years with Dr. Edna Foa, who people will probably know as the developer of prolonged exposure therapy. So in that setting, I had really comprehensive training in PE and exposure therapy for other disorders, and benefited tremendously from her mentorship, and just really got into both clinically and had opportunities to get into the research of PE, which I've continued to this day in my career.
Yeah, great. And Liz, how about you?
My interest in psychology began, I would say, probably in high school. I took a psychology class in high school and was just really fascinated by it. And I had been looking forward to taking that course for quite some time. So I sort of, although I didn't have any parents or relatives in the field, it was something I always felt like I was interested in doing. It was probably one of those annoying college freshmen who knew, and declared their major quickly, and kind of felt like I was on this path to studying psychology fairly early on. But I also had a liberal arts education and learned a lot about different, took a lot of philosophy courses and religion courses as well. And through that started to get interested in acceptance and mindfulness-based therapy. So when it came time to apply for graduate school, I was really actually very interested in studying acceptance and commitment therapy. And I ended up at Drexel University in Philadelphia working with James Herbert and Evan Foreman. And they were applying ACT in the context of treating social anxiety disorder. And so I became very interested in anxiety disorder treatment and exposure-based treatments, as well as mindfulness-based treatments for social anxiety. And while there, I started collaborating with a fellow graduate student on the use of technology in implementing treatments, and was very interested then in this idea of how to make treatment more accessible. And around that time, I did a clinical training experience in graduate school at the Center for the Treatment and Study of Anxiety Disorders, where I met Dr. Edna Foa, and was very fortunate to be able to have a prolonged exposure therapy case while I was there as a practicum student. And in fact, that's where I met Carmen. I would say my interest then really shifted, and I really credit Dr. Foa for leaving that sort of mark on my own training, because it really shifted my direction and getting very interested in prolonged exposure therapy and the treatment of post-traumatic stress disorder. So I, shortly after that, went on internship and ended up out at the San Diego VA, and I worked with Stephen Thorpe, and then took a postdoc position in Boston at Massachusetts General Hospital, where I worked with Naomi Simon and got more experience in the treatment of PTSD and working with veterans specifically. And again, I really have to say I credit Edna Foa for setting me on that course. And it's been kind of rewarding to go from there.
That's great. And I think we've been talking about having both of you on the show here for a while. It feels like this has been kind of months in the making. And I think now we're recording today, and timely in that recently Edna Foa, who both of you trained with, for those that don't know, passed away at the end of March. And I think talking about what you have done and the legacy of her work is so important. And maybe before we get into the topic, anything that you all want to share about Dr. Foa. And I had only met her once in my career in Philadelphia doing training. I still say today it was one of the most intense trainings that I went through in just a couple of days. But anything you want to share about her before we get into the topic of her work?
Well, thanks for mentioning that. The timing is somewhat bittersweet. And Edna was a really formidable figure in the field and a true pioneer in developing PE and leading many of the foundational studies on PE, co-developing the theory that underlies PE, leading massive global dissemination efforts to train providers in PE. All of that is part of her legacy. And we were very lucky to have Edna write a foreword for our book, and very, very sad to learn of her passing.
Well, and I'm so glad we have the opportunity to expose people to her exposure work today, and I appreciate the two of you being with us to do that. And I think maybe to start, we often hear exposure and terms like that, and I think sometimes when we talk about prolonged exposure, I think as people who are not in the profession, they question what that is. But I think even some people in the profession maybe don't understand what prolonged exposure is. Would one of you maybe be able to kind of share with us a little bit about when we say prolonged exposure, what does that actually mean?
Well, it's a bad name. I think we could acknowledge that. It sounds like the opposite of what anybody with post-traumatic stress disorder would want to sign up for. And that is a recognized issue in the field. And actually, there are some people that are working to try to problem solve that a little bit and think about some different language that can accurately describe the treatment in terms that are a little less intimidating. But yeah, I'll let Liz, I know you're going to explain what the treatment is. So take it away.
And now a word from our sponsor. PAR's AI Report Writer is an AI-boosted tool that generates comprehensive reports, including interpretations and recommendations based on scores from a wide range of popular assessment tools. Spend less time on report writing and more time supporting students. Learn more at parinc.com/AI. That is parinc.com/AI. And now back to our conversation.
Well, and I appreciate Carmen's point too, because I think it is an intimidating sounding name, but in fact, what it is, definitionally is it's an evidence-based cognitive and behavioral therapy for PTSD with an emphasis on behavioral approaches. So the focus of the treatment is really on helping people confront in a gradual way avoided memories and situations related to their trauma. But it's important to note that this is done in a very collaborative way. It's done in a gradual way, and, it helps people process trauma memories that have been, plaguing them for, in some cases, many, many years by the time they come to treatment. And so it really is a life-saving treatment. And I just want to echo again the legacy of Edna Foa, because she really has left behind a legacy of life-saving work with this treatment.
So, one of the things, and I think, Carmen, you kind of shared, the name makes it sound like something that no one with trauma would want to go into. I have a love-hate relationship with social media and TikTok and all of these other things out there. But I think sometimes there is misinformation where people are saying, oh, it actually re-traumatizes people, or it, can you maybe, either one of you may share a little bit about kind of your thoughts on some of that, because that misinformation that gets out and why it doesn't, like why that is misinformation.
Sure. the name prolonged exposure is accurate from a sort of a therapeutic technique perspective in terms of the technical terms that were developed in the field. Although it turns out it doesn't maybe need to be quite as prolonged as was originally thought when the treatment was developed. And then, clinically, many exposure therapists don't even use the word exposure with their patients for the reasons that you raised, because of the negative connotations. And when we hear exposure, we think about toxic, exposure to some sort of virus or something negative. Personally, I think, Liz, you said the word confrontation. I like the word approach, helping them to kind of approach these things. And really the foundational idea of prolonged exposure is that avoidance is maintaining the symptoms. Therefore, we are going to invite the client to stop avoiding and instead take the opposite approach. We're going to invite them to approach the trauma-related memories and situations and so on. And we're going to do it, as Liz said, in a way that's systematic and with support and encouragement and all those things. Yes, there is some misinformation about exposure therapy broadly, including PE being really difficult to tolerate, causing, retraumatization. People are going to drop out, they're going to get worse, etc. And those misconceptions are oftentimes held by mental health providers as well, perhaps even more so than the public, which is a real barrier from a dissemination perspective.
And I just want to underscore that point because, a lot of times, when patients are coming to treatment, they're coming because they have been troubled by the fact that they're not able to do the things that they used to do or to engage in activities that used to be really meaningful or valuable to them. And so the prospect of helping people regain control over elements of their life and regain control over their memories is something that to many patients sounds like a relief, like a path forward.
Yeah. And that, the concept of that it's sometimes more uncomfortable for the clinician, I think such an important piece because I remember being a doc student and having the first time that I had to do it. And I was scared to death. Like I'm going like, oh my gosh, like how am I going to make people stay in this moment? And I think we need to do more with training people to be uncomfortable with that. And it's like, where we don't realize how much we can help people move forward and push them because we're concerned about that. And, I know both of you are in training. How do you work with clinicians to help them overcome some of their own anxiety about doing exposure work?
It's definitely a big challenge. I think you're right. Like mental health providers go into their field because they want to help people and they want to help them feel better. So it can be, and particularly with certain sort of training backgrounds that they have or philosophies, it can be really difficult to encourage them to do things in the therapy room that will cause some temporary distress or discomfort for their client. I think part of it is you can kind of provide education and you can show them the research and you can show the data saying, look, sometimes there's a bit of an increase, but even in the minority of cases where that happens, it doesn't increase their probability of dropping out. It doesn't limit their probability of recovering from PTSD. And for most patients, it actually doesn't even happen at all. Typically, symptoms show a pretty steady decrease from session one is the sort of most common trajectory. You can provide all of that, but I think it's not going to get people to where they need to be because, and this is the behavioral model, is that we learn best through our own experience. And there's nothing more compelling than your own experience. And so that's where it's so critical to have opportunities to implement the treatment with consultation. And that is a real challenge. And that's, it's resource intensive. And not everybody has those opportunities, but that I think is ultimately what is really needed is for people to have the opportunity to try it and to see that the client doesn't fall apart and that it's okay. And to do that with consultation and support and encouragement of somebody with more experience with the treatment. Because if you don't have that and I'm going to try it out, I'm going to give it a go, but I'm really not sure. I'm a little hesitant. I think let's just dip our toe in the water a little bit because, I don't want to rush it. This might be a little dangerous. If you hold those perceptions, your client's going to pick up on that and they're going to know, gosh, my therapist doesn't seem very confident that I'm going to be able to do these exercises. I'm picking up on some signals that maybe this isn't very safe for me to be doing this. And then, I think you risk having a bit of a self-fulfilling prophecy where they end up not doing that well because of overly cautious delivery of the treatment.
Yeah, I always say like my experience, as nervous as I was, I think the two best parts for me was one, that I had a mentor who sat with me and who helped me who modeled and helped show. But the other thing was, after the experience, seeing the progress and seeing someone have the relief at the end was a game changer for me. And the next time was so much easier because I think you use the word temporary distress. There was this temporary increase and it was uncomfortable. But then at the end, the sense of relief and empowerment, I think, that comes from it. I've been doing this for a long time. I still remember that moment in training and kind of going, oh my gosh, this is what it's supposed to feel like, right? It's like there was this difference. Yeah. But I think it is hard to get that mentorship, that somebody can help sit with your own emotions with it as well.
Right. And sometimes just reassure you that you're on the right track with what you're doing, even if you're seeing high degrees of distress, and thinking about how to tailor the treatment accordingly, or
absolutely
just provide that encouragement to keep going.
Yeah. One of you had mentioned the idea of prolonged exposure being an evidence-based treatment. And I just want to maybe take a second to visit that, in the sense that, I know what my experience has been with it, and I'm sure you all have, clinical experiences. But can you talk a little bit, what is the evidence supporting prolonged exposure around PTSD?
Sure. So PE has the distinction of being the most studied protocol for PTSD. So not to say that it's necessarily better than there are several other treatments for PTSD that also work very well, but it has the distinction of it's just been studied a lot because it's been around for a long time. And for whatever reason, people around the world have been interested in evaluating this treatment. So there's a lot of randomized clinical trials that have tested PE. And that's important because every time it's studied in a slightly different population, in a different context, in a different setting, maybe slightly different methods, so on. And so when we step back from this body of research, we are in a pretty good position to say with confidence how well this treatment works and how safe it is, because we've seen the same finding again and again and again and again and again. So we know that PE works better than nothing. It works better than sort of many non-specific kind of interventions. It does not work better necessarily than other trauma-focused treatments. It probably works better on the whole than non-trauma-focused treatments, although not every single study has found that. But when you step back and you look at meta-analyses, that seems to be the case. So based on that, PE is recommended as a first-line treatment by all major clinical practice guidelines. And what else would we want to say about this, Liz?
I want to underscore, too, that it's been studied in a lot of different populations, with a variety of different trauma types, sexual assault survivors, combat veterans, people with multiple traumas, and I think we could add that to the list of misconceptions that sometimes people think you can't treat PTSD with PE if people have multiple traumas. because of the focus usually on one specific index event. We know that's not true. It does work effectively for people with multiple trauma exposures. It's been shown to be effective in older adults, adolescents. And so, again, just to emphasize that its applicability and effectiveness across populations is fairly robust.
Yeah, and I just want to kind of maybe add to that. I think, the other part in kind of my research of it is, when we're in a kind of a world right now where research gets questioned quite a lot, and there's a whole lot of opinions out there. We talked earlier about Dr. Foa, and I think the amount of studies done not by the founder, the fact that this has been studied by people all over the world, and while her name shows up robustly on papers, the number of, I think, researchers who independently studied it and had no kind of ownership in it, I think also speaks highly. I mean, I think we see a lot of research that someone develops something and then they do their own research and it always looks good. To see how many studies outside of those connected with Dr. Foa is quite impressive.
That's right. And you get then a different spin on how this treatment can work in a variety of different treatment contexts, different treatment formats with different comorbidities. And so it's really, again, a really impressive body of work by a variety of different researchers.
Yeah, absolutely. So I want to move here. When I had reached out to speak with you all, what caught me was the book that the two of you put together. So book Prolonged Exposure for PTSD. And I guess I'm interested in what led you all to write this book.
So the impetus for putting this book together was, it builds really well from the past question, because we have a lot of research that's evaluated PE. We know that PE works as a treatment for PTSD. That's quite well established. What we wanted to really highlight in this book was sort of the next level or the next wave of research that has tackled a broader range of questions. So we're past, does it work? We know it works. This book is all about kind of compiling the latest state of the science around a different set of questions, which is, how can we get this treatment to more people? How can we better engage people in this treatment? And also, how can we make prolonged exposure work even better with more people? So that was the impetus for the book. We were so fortunate to get to work with really the top leaders in the field on a variety of different topics related to those questions. And of course, it was lovely to work with Liz in putting it together.
Yeah, as I had the chance to read the book, I think one of the things that caught me as a practitioner were ideas that I didn't think about, especially around things like just exposure in telehealth and virtual reality and all of these pieces. I was like, oh, this is kind of exciting. This is, a really different, kind of way to look at things. And also, I think the adaptations culturally were really, was a really great part to kind of look at, and things that, where I live and practice may not see on a regular basis, but to have that resource available, I really kind of appreciated that.
The other thing I should mention in terms of the motivation for this book was to take that kind of latest and greatest science of prolonged exposure and also kind of frame it in a way that is, here's what this means for practicing clinicians as well. So what are the takeaways? What does this mean clinically? We have a lot of the chapters include kind of a case study, or they have kind of here's the clinical implications of this research sort of section. So that was another really important piece, is to kind of help put this state of the science into what it means for those that are treating PTSD patients.
So when we're talking about delivering PE, what do you all see as some of the specific barriers that come into play in practice?
Well, I think we touched on some of these. And when I think about the barriers to PE, I think about different levels of the barriers. I mean, there are, some on the patient level, there are barriers just because of the nature of PTSD. Avoidance is a big part of the picture, sometimes mistrust. And so these are things we are attentive to as clinicians. But then there's just sort of the practical barriers associated with PE. As Carmen mentioned, when we're delivering it, it can be resource intensive on the part of the therapist and the client. Typically and traditionally, it's been designed to be delivered weekly or twice weekly, 90-minute sessions. That's quite a time-intensive commitment for patients who also are being instructed to do a number of between-session exercises as well. So there's a big time investment practically with the treatment. Therapists, of course, we talked about some of the therapist barriers and beliefs and misconceptions around exposure. And, being now in a university setting, I'm also becoming more acutely aware of how little training we give graduate students, even in multi-year graduate programs, on delivering prolonged exposure, and even treating PTSD, getting into the very specifics of treating PTSD. And so I think we have some systemic and institutional barriers as well that we're facing. There are too few providers to deliver PE. And when most people who do get trained in this, which may be, early in their career after graduate training, consultation, we know, is a big part of what makes that training effective and more likely to be implemented and actually brought to patients. But without that, that consultation itself is also resource and time intensive and financially intensive sometimes, depending on the situation. And so what this all leads to is far too few people are getting PE, much less any other trauma-focused CBT.
As I was kind of reading the book and as you all were talking, I live in a much more rural area of Pennsylvania, and, some of the locations around me, one of the big issues we deal with is access because of geographic distance. We have, people in Philadelphia 2 hours away that may do this work, or, maybe an hour in Harrisburg. But many families, I think, struggle with one of the barriers we see is the access in our area. So with the idea of the push of virtual care and telehealth, what is the research around that? Do we see the same effectiveness in telehealth? Or I know I've seen some web-based prolonged exposure programs, and I guess I'm kind of curious on your thoughts around that.
I mean, by and large, the evidence shows that PE delivered via telehealth versus in person is roughly equivalent. We don't see, through a number of non-inferiority trials, treatment delivered via telehealth synchronously with a therapist is as effective as in person.
Wow.
Sometimes there may be some idiosyncrasies that one has to manage with respect to the client's own comfort with technology or troubleshooting how to ensure homework adherence occurs and to maintain optimal engagement and in session emotionally. But for the most part, these modalities are as effective, and that people can still develop strong alliances and clients do very well in them.
Yeah, so that's good news in terms of addressing geographical barriers to accessing treatment, but it's requires the same amount of expert therapist time. And
right.
So there's other strategies that people have explored that potentially could help address some of the other barriers related to kind of a fundamental problem of we do not have the mental health workforce to address the burden in the US or globally. And also not everybody wants to get in-person psychotherapy. Not everybody probably needs to get in-person psychotherapy, as that not everyone needs that level of care, not everybody wants it. And so there's other strategies, as I said, that people have explored, some of which involve looking at using technology in different ways, like through web-based treatments or even mobile apps. So some of that work, those are not really, there's nothing really that's like publicly available that is widely used right now. But there have been research studies looking at that show that it's quite promising. I think there was concern that, probably particularly for prolonged exposure, that it might be really dangerous to have people do the sort of trauma memory revisiting outside of a therapy room with a provider. I think that was a concern really for telehealth as well. And then, now with the telehealth is so widely adopted that I think that concern has been mitigated. But I think it's still there very much for doing any kind of self-guided exposure, which some programs have tested that kind of where the patient is doing pieces of the therapy kind of on their own. And then maybe they're checking in with a therapist. Maybe they're not even checking in with a therapist. Maybe they're checking in with somebody else who's received some training and is monitoring things asynchronously. So that's kind of relates to another strategy, which is called task shifting or task sharing of the roles or tasks that the mental health therapist would typically be doing to another less expertly trained person. And this is a strategy that's been used in different parts of the world where there's really even more limited pool of mental health providers to try to increase the mental health workforce. So that's another strategy. And there's some work that's looked at that in terms of the delivery of PE as well. So those are some other really exciting strategies. And those are described. The latest research on those is also described in our book.
I hope I'm not giving a wrong information. What I have heard and kind of, I think what I've seen in the literature is that dropout being kind of a common barrier with some of the standard weekly PTSD treatments. And I think Liz used the word kind of this intensive outpatient work, that what you're talking about with exposure seems more intense and frequent than just weekly sessions. And am I right in that the more intensive approach helps with dropout versus these kind of weekly sessions?
Yes. And I would say, so dropout is a concern. It's a concern in psychotherapy in general. It's a concern in evidence-based treatments for PTSD. Dropout rates in PE are about 20 to 25% in clinical trials, higher, maybe about a third to 45% in routine clinical care settings. But these rates aren't necessarily different from other trauma-focused CBTs. And one thing that is really promising for addressing this barrier are these intensive treatment models. So there have been some treatment models that have looked at condensing PE into 2 weeks, 1 week, a few days even. And what this essentially does is it provides sort of an accelerated course of care and condenses the dose of treatment in a shorter time frame, which provides fewer opportunities for patients to drop out essentially. And they're often done in intensive outpatient settings or residential-like settings. But many patients like that idea of not having to have the continued disruption of weekly or twice weekly appointments for several months, and instead find it easier to perhaps just take, or a couple of weeks, or in some cases even around a weekend to get treatment for their PTSD. And the dropout rates in those trials are really low, in some cases less than 5%.
So I think that's really interesting. And it kind of goes back to maybe what we started with. The name prolonged exposure might sound, that's not the right name, given that we're saying that this intense exposure within a shorter time frame keeps people in longer and has maybe better outcomes.
I don't know if the outcomes are necessarily different, but yes, definitely the dropout is far less. So in that sense, it's a big success.
I'm convinced that masked or accelerated formats are really the way to go with treating PTSD. when it's feasible, and it's not going to be feasible for everyone. But when it is, I really think it's the way to go for PTSD and probably for any disorder that's characterized by avoidance behavior, and probably particularly for therapies that are more challenging, like trauma-focused treatments, including PE. Because when you're in a treatment and you're doing it every day, there's more like therapeutic momentum. You don't have to remember what was the homework I was supposed to do last week and what did we talk about again. When it's spread out over multiple weeks or months, they're just more things to come up in life to interfere and something to get in the way of completing the course of treatment. So you're really minimizing that when it's condensed. And as I said, you have more sort of momentum in the therapy. It's all, you're really focused in on it and locked into the treatment. And so, as Liz said, patients seem to really like it, and therapists also seem to really like it. There's been research that's looked at sort of patient or provider experiences of delivering this model of care, and providers also really, really like it. It's nice to see your patients get better so quickly.
Right.
And then,
well, and
I just want to say one other thing from the patient perspective. You're not battling with yourself every week of like, do I want to go back to this? Yes, I know I should. It's probably, maybe it's helping. It's difficult. It's uncomfortable to do the work of these therapies. And so to have like a week in between sessions to like battle with yourself around like the motivation to continue and to engage with the treatment. It's like really making it harder for them.
Yeah. And that's kind of what I was going to say. I mean, I think, knowing that it's going to be intense, but short, it's hard work, but it's not like, oh, it's going to be 6 months before I actually feel well. And I think whether that's the momentum or just our ability to maybe tolerate, because it's like, okay, I can get through this intensely for a few days. Yeah, I think it changes mindset to some extent. I'm just curious. So as we're talking about this intense kind of model, how long is a typical session? Like, so if we're doing it in this intense massed approach, how long is a session each day?
I think it depends to some degree on the setting. But in my experience, having done these in a couple of different models, the sessions are not too different in length. What differs is the number per day, perhaps. In some cases, maybe 2 sessions a day of typical lengths. Or once a day over a period of, say, a week or 2. And oftentimes, if they're delivered in the context of, say, an intensive outpatient or residential type program, the patient is getting other programming oftentimes alongside their PE sessions. But in other cases, not that we're saying that's necessary for them to have in terms of their PTSD. So in other cases, if this is done more in an outpatient setting, it might look like committing to coming in every day and meeting with the provider. So I think these models can look a little bit different, just sort of depending on the broader system within which it's being developed or delivered.
I guess I'm curious, what are some strategies that you think clinicians can put in place that might help improve outcomes for specific groups?
Well, one of the really neat things about this book was seeing the different ways PE has been adapted. Although I'll say it was equally sobering to see all the different ways we still need to work on adapting PE.
Sure.
To reach even more people. But some of the adaptations for PE to specific groups have focused on adolescents, older adults, as well as different comorbid symptom presentations. And so depending on the client you're working with, it's always important to ask yourself, in addition to knowing the treatment and implementing the treatment with a degree of fidelity, particularly around the core mechanisms of exposure. It's also important to think about who's the client sitting in front of you and what are their particular idiosyncratic and contextual factors that might allow you to have some flexibility or think about how you tailor the treatment. Some people have put these together in more systematic ways. And in one example, this is working with adolescents. So for instance, PEA has been developed to address PTSD in adolescents. And some of the adaptations include some pretreatment components to help with underscoring autonomy, given the developmental stage of the client, some flexibility in terms of allowing for extended sessions and opportunities for caregiver involvement as well, or supportive adult involvement. With older adults, some adaptations include things related to accessibility, which could be as simple as providing handouts with larger text, larger print materials, making sure office spaces are accessible. There's evidence to show that integrated care models with older adults can be more effective when providing mental health care. And again, pacing, flexibility, maybe a longer period of relapse prevention to help with generalizing learning, and some focus on nurturing the alliance without fragilizing older adults also. So those are some ways that we might think about making adaptations to particular age demographics. And then with respect to different comorbidities, there's also been developing protocols to treat people with comorbid substance use disorders, as well as comorbid borderline personality disorder, DBT plus PE, and the COPE protocol for people with comorbid substance use disorder. And then maybe less researched, people have looked at adapting PE with patients with bipolar disorder, psychosis, suicidal ideation. Comorbidity is the rule, not the exception in treating PTSD. And so having ways to think about how to adapt or incorporate other protocols alongside PE to manage the co-occurring needs of these clients is really important. And there are a number of chapters in the book that outline specific strategies and the evidence around these approaches.
Yeah, that's great. Thank you for sharing that. You mentioned about the DBT PE, and it's something I have found quite interesting because I've worked with therapists or supervised therapists that were concerned about doing the safety of delivering some trauma-focused treatments with borderline personality disorders, specifically around high suicide risk. Could you share a little bit about how DBT PE protocols are structured and how you see that as maybe why it is an effective treatment with that comorbidity?
Yeah, and I guess I'll just start by saying that, a sizable, minority of people with PTSD, probably somewhere around a fifth to a quarter, according to some studies, meet criteria for borderline personality disorder. And I don't know the exact rates on suicidal ideation, but, it's prevalent in people with PTSD. And so certainly encountering that risk is not uncommon, and it's important to know how to manage it as a clinician. With respect to DBT plus PE specifically, I know there's a period of about a year where people do DBT skills coaching and ensure that people have DBT skills available. And PE is started when there's been an absence of self-harm and acute suicide risk for, I think it's a period of about 2 months. And with respect to suicidal ideation, really is no evidence to suggest that withholding PE from people who have SI is beneficial. Certainly, you don't want to be doing PE with someone who is acutely suicidal because they likely need to do some safety intervention to make sure that they're safe. But once the acute risk, the imminent risk has passed, more and more the guidance suggests that people should be working to treat PTSD if that's the core part of the clinical picture.
Yeah, that's great. And I'm so glad you mentioned about the kind of the building of coping skills prior to the PE and, building that distress tolerance and emotional regulation and building some of those skills. But no, that's very helpful. As we're kind of running maybe kind of toward our end here, I want to just kind of one more question. If maybe you could share a little bit about what are some of the recent developments or emerging trends that we see about how PE might be delivered in the future? As this seems like it's a continually evolving field, what are some of the emerging trends out there?
Can I go back to something else really quick before I go
Of
to
course. Yeah.
Because you
Stabilization.
Exactly, Liz. Completely true in the DBT-PE model that there are certain sort of clinical safety metrics that they look for before moving on to the PE implementation phase of the protocol. DBT is still sort of underlying the whole period of the course of treatment as well. So that's an accurate characterization. But it did make me think of something we talked about earlier, which is about kind of maybe misconceptions about prolonged exposure. And one of the common misconceptions is, and it's related to kind of these concerns about exposure and its tolerability and its safety, is that, as we talked about before, the sort of overly cautious maybe delivery of exposure therapy. And there is a perception, a commonly held perception that exposure therapy is only appropriate after some period of sort of stabilization and teaching the client emotion regulation skills and stress tolerance. Now, it's kind of a tricky subject because I think clinically that may well be the case for certain clients. So I'm not suggesting that that is never a clinically appropriate treatment plan, but it does not, the data do not suggest that as a rule that spending time doing skills training, stabilization, what have you, prior to initiating PE or any kind of trauma-focused treatment really seems to lead to better outcomes. It makes kind of a lot of clinical sense, and it fits sort of intuitively with how we might think of, let's do something and sort of prepare them to do this more difficult thing. And so that it's sort of widely assumed that that's helpful. And the data just do not strongly support that assertion. And there have been studies that have looked at, just going straight into the exposure versus doing an initial sort of preparatory phase first. And they're not showing different outcomes. And actually, there's a study I just saw recently that looked at emotion regulation, and they thought presumably emotion regulation would improve during this initial phase, and even if outcomes aren't different. And they found that emotion regulation improved just as much when you went straight into prolonged exposure. So we have often sort of these clinical assumptions that really aren't borne out when you do clinical studies of them. So I did want to mention that. I couldn't.
No, I think that's very interesting and great. Is there, for the clinicians listening, is there anything you would suggest that if they are going to go into exposure right away, are there any things that they should kind of be aware of that might say, okay, maybe it's not a good idea? Or are we saying that pretty much no harm if we go in straight into PE with some?
I think the contraindications to PE are the same contraindications for initiating any treatment for PTSD. So like Liz said, if your client is in acute risk of suicide risk or some other negative outcome, clinically, you should be addressing that, and you should not be proceeding with any kind of PTSD treatment. And beyond that, I would generally say no. But I'm interested, Liz, in if you have a different perspective.
No, I generally share that perspective. And I think it's so important, though, to take into account the individual client in front of you and have a strong conceptualization of the case and what their comorbidities are and how they fit into the PTSD, and use shared decision-making and collaborative discussions with your patient to discuss the treatment plan ahead of time. But I think when you're dealing with comorbidity, if you're conceptualizing PTSD as the primary issue, to Carmen's point, delaying treatment for that risks making all the other comorbidities worse. And so what happens is clinicians start treating all the comorbidities first, thinking they're going to prep the person to start PE. And because that underlying primary symptom driver of everything else, the PTSD, isn't ever addressed, it ends up prolonging treatment and sort of reducing the traction that people can get. And I'm sort of speaking broadly. So I think a helpful thing might be to think about what are the comorbidities. And if I'm starting to treat their PTSD, are the comorbidities improving or are they getting worse? If they're getting worse, then maybe it is important to pause, take stock of what you're doing, go back to your conceptualization, revisit it with the patient to determine if you really have the right plan there. But often the cases is you start treating the primary PTSD, the other things start to improve as well.
Yeah,
the PTSD has to be primary. I mean, if they're so depressed that they are not able to get to sessions, or if their substance use is not managed and they're not able to participate in therapy and be sober, like those kinds of things that would be really interfering with treatment.
Yeah, I'm so glad you kind of came back around to this, because I think, as you both were talking, I was like, yeah, it kind of goes back to that that word you said earlier, momentum, that if treating the PTSD and building that momentum may help with those other comorbidities. And sometimes as clinicians, maybe our misconceptions or our own anxiety about pushing into the trauma work too early, in the long run, we're actually delaying progress. So glad that's such a great kind of point to come to. So I appreciate that. Well, as we're wrapping up, we like to end our show with two questions that we ask all of our guests. And first question is kind of a general question. We always ask if people could, our guests could share one piece of content, whether it's a book, a movie. We've had TV shows. We've had Home Alone be recommended. I mean, we've had a variety. But for those in the profession, if each of you could maybe share one piece of content you would suggest for people to check out.
Want to know what Home Alone was recommended for?
The best movie to understand the mind of a curious child.
I can see that. Well, Liz and I talked about this the other day, and one thing that came to mind for me in terms of like media was a film that I've seen quite recently, which was called Train Dreams. And this is a really beautifully filmed film that depicts the experience of a man who witnesses trauma and experiences traumatic grief. They lose, well, I shouldn't give it away, but they experience trauma. And then the film just really depicts the experience of traumatic loss and post-traumatic stress. It was quite accurately, I would say. And so that was a really interesting film. I recommend.
Great.
I'll second that. It's a beautiful and poignant movie and story. And for me, one of those that sort of stuck with me for a few days after I watched it. So I was glad Carmen mentioned that one. I wanted to recommend a book called Everything is Tuberculosis by John Green. I picked up this book not really knowing what to expect. And I would imagine like others didn't think TB was sort of this, I think of it as sort of this old disease, but in fact, it's the most deadly infectious disease in the world. It continues to be. But the author's thesis is that TB is no longer, at least in the 21st century, caused by a bacteria. It's caused by humans because we have effective treatments for it. But systems, capitalistic structures, human choices have sort of contributed to the persistence of this disease. And in a really compelling way, he talks about how systems of care and persistent health inequities have kind of contributed to the reality that this disease remains so deadly worldwide. And so I think it's a must read for people who are interested in bridging the gap between evidence-based treatments and their accessibility, and who are grappling with this question of, and sometimes in an infuriating way, like why is it that we have these very effective tools and so few people are getting them and receiving their benefit?
Thank you both. Those are great. There are two that I'm not aware of, so that'll be good. So I usually don't add to it, but since we mentioned Dr. Foa earlier, I'm going to throw one in for our listeners that one of my favorite books as a doc student was Failures in Behavior Therapy that she edited back in the early 80s and still relevant today. And for those who haven't read it, it's still kind of on my list. So if people haven't read her work, it's one that I was introduced to as a doc student. And still, when you read it, you go, wow, we're still making the same mistakes and failures many years later. So it's a good one to revisit for people. As we wrap up, the last question is, and we'll let you guys tag team this last question, but what are maybe 3 takeaways that you think from today's episode you want to make sure that our listeners walk away with?
One that comes to mind is, this is really what the whole book is about, is that there's so much cool work happening that is putting everything we know about treating PTSD is being questioned. Like, okay, can people get even better than what we're seeing? Does it have to be once a week? Why? Does it have to be a therapist? Does it have to be in person? All of these things, let's question it. Let's do the science. Let's really push the boundaries. So there's really a lot happening. And I hope people will be interested to learn about the different ways of kind of taking something that we know works and kind of packaging it and delivering it in ways that hopefully will reach more people and help more people.
Yeah. And I'll say another takeaway that I hope people find in listening to this is that exposure and PE are not harmful techniques and that they're life-saving in many cases. And that some of our anxieties about implementing them might just be that, our own anxieties.
Right.
I might also just add one other thing, if I could, which is that, we're talking a lot about PE, but there are a lot of evidence-based treatments out there. And one thing we also hope people take away is that we hope that if they are looking to treat PTSD or have their own PTSD treated, we hope that we've made a good case that it makes sense to start with an evidence-based treatment like PE. But know that there are others out there as well.
And no one treatment is going to work for everyone. So It's good that we have options, but yes, shared decision.
Again, that's right. Well, I want to give a big thank you, both Carmen and Liz, for joining us on today's episode and talking about prolonged exposure. For our listeners, we'll have in the show notes about their book, Prolonged Exposure for PTSD, Innovations to Improve Access, Engagement, and Outcome. I hope you all check it out. Great read and a lot of great tips in the book. If our listeners are interested in learning more about your work, where can they follow you or find more information about each of you?
You can find me on LinkedIn.
LinkedIn.
Yes, same. Also on LinkedIn.
All right. So LinkedIn for anybody that's interested. And for those licensed clinicians who would like to use this information for continuing education, please head over to www.psychedpractice.com or check the show notes for an accompanying CE exam for this episode. If you're interested in learning more about Psyched to Practice or staying up to date with what's going on, you can visit our website or you can follow us on all major social media by searching Psyched to Practice. We will be back in 2 weeks, but until then, be well and stay psyched.